All right, thank you, James, and thank you to the committee. I'm honored to be among such very distinguished colleagues. So there'll be a few nods to Silicon Valley, where I'm from, at Stanford. So I've described our experience as a leaning in for palliative care. So the first kind of point I wanted to highlight actually was that this is not new. This is another nod to Silicon Valley, that even before the law, our End-of-Life Option Act, that we'd always gotten requests and consults in our palliative care service in our clinic for physician-assisted death. And so in the months leading up to the implementation of the law, we'd had a number of requests where things that came to us as PAD were often something else in the guise of PAD. An example that I wanted to give was an elderly gentleman. This is a very typical case coming out of the ICU, history of Parkinson's disease, had a pneumonia, has a nasogastric feeding tube down his nose, and something just happened. And he'd been repeatedly requesting to his primary medical team that he wanted the lethal prescription to end his life. And the team, kind of feeling quite hijacked, calls palliative care and ethics in consultation. So they're pretty much freaking out. And suddenly it's this discussion of PAD and, oh my goodness, what are we going to do? And when we talk to the patient, a la Dr. Bach's kind of acronym around listening and just hearing what are the reasons why you're asking this right now. And he was basically distressed by having this nasogastric feeding tube and this existence of being in bed. And he's like, this is not how I want to live with a nasogastric feeding tube. And we said, you don't have to have a nasogastric feeding tube. And this led to a discussion of what limits he wanted to set on different interventions. And he ended up with a POLST. This is not a request for PAD. And so what we were finding, and we have continued to find, is a lot of these requests for PAD are often patients and surrogates not distinguishing between these discussions of PAD, of refusing unwanted treatments, in the context of just wanting to talk about end-of-life issues and trying to figure out a vehicle to do so. And so it was important that we recognize that. In our process, so we actually very much appreciated the experience of Washington being published in the New England Journal of how we deliberated as an institution regarding our participation in that process that was actually led by our ethics department. We had a series of town halls, 20 of them, talk about herding cats, but that gave us an immense sense of perspectives and hearing the voices of our colleagues. And pretty much everyone had an opinion about what palliative care should be doing as part of this process. And so to highlight a few kind of very prevailing views, palliative care should be the prescribers. And for some, they thought palliative care should be the sole prescribers in PAD. And this was from a group of often clinicians who were supportive of the legislation of this act, but did not want to be involved in the process and thought palliative care would be the experts in this. Another group who were opposed, who said if we are going to participate, palliative care and ethics and psychiatry and everything we could possibly think of should be put in place as safeguards in the process for patients. And finally, another group who said, don't be in our business. So they wanted to maintain their relationships with patients. This in particular was a view of some of our primary care colleagues who felt very strongly about the integrity of their relationship with their patients and that they wanted to keep things kind of within their tribe and that why would we even need a policy or a process? Because the law is in place. And so what they all agreed on was that these patients, as we have heard yesterday, these patients have palliative care needs. And so with that, to give a sense of the landscape for palliative care, so our program's been in place for about 10 years, and in the beginning we were often just demonstrating that we do no harm, that palliative care is here to help. We are now integrated and involved in rounds for bone marrow transplant, in oncology, in our ICUs. However, we are still hearing this. And so this is a couple months ago, I heard this from one of my cardiothoracic surgical colleagues who said, well, when I hear a palliative care is called and is coming to see a patient, I assume that you've been called to withdraw treatment. And he continued on to say, and sometimes I'm worried it's too early. And so this has been a continuous struggle for us, and we still continue to disarticulate palliative care from death and from hastened death in particular. And so as a program, as clinicians in palliative care, we didn't want to be in the position of prescriber officially, certainly as what some colleagues had been suggesting. And we wanted to strive to facilitate dialogue in this process, not necessarily death, just as a program. And so to give a sense of what our process is like, I'll highlight briefly some differences that came about that were added that are not in the law, that's part of our policy, and then talk a little bit about how palliative care has been involved in this landscape. So with the implementation, we have put in place in our policy required ethics consultation. Now, this is not the ethics committee descends on the patient and the clinician. This is not the full meal deal ethics consult. It is a call from the attending physician to the ethics consultant at the initial request. They act as supports, resources, navigator, can answer questions. They also help direct kind of traffic as physicians who are attendings who are not willing to prescribe. They help the patient connect to the social workers who navigate that patient to attending who is willing to prescribe. We also require completion of advanced directive and POST as part of our policy. That's not in our legislation. For palliative care, when I say leaning in, we really leaned in. And so we are actually part officially of the process of PAD at our institution. And so I wanted to actually use the actual language from our policy. So we take on the role of the willing consulting physician in palliative care. And so what this means is that as that consulting physician, we both serve as the consulting physician and to explore available options which may not have been discussed, including physical, social, emotional, and spiritual assessment. This will also provide access for the patient and their family to the range of services from the palliative care program. And that was really one of the major areas we wanted to focus on. Our service, we have unique services to offer for this group of patients. We have a multidisciplinary team in all of our clinic sites, including physicians, nurses, social work, and chaplaincy, to address all these different needs. And we have a pediatric anticipatory guidance program for patients who are parents of children under age 18 that offers counseling to parents, to the patients, to the children. They do bereavement support afterwards. And so it's a really unique service. And we want to make sure that these patients have access to our program. So our experience has been, actually, we've needed to expand who can be the consulting palliative medicine physician. That the reality is that patients are often becoming sicker in this process. They're maybe at home on hospice, and their hospice medical director can serve as the consulting physician. They may be outside of our region. We have patients coming from multiple counties over, from Modesto or Fresno, et cetera. And so it can be someone locally for them who's a hospice or palliative medicine physician. As we heard from Dr. Koenig, no physician, palliative care, or otherwise wants to be known as the go-to for PAD. And so that was something that we had heard over and over again from within our group, from outside of our group. And then the question has come up is, how do we triage PAD patients in our palliative care clinic? There is a sense of urgency, not just for us, but for attending physicians, of seeing these patients soon. Does that trump patients who are coming in for acute symptom management, who have other needs? And so thinking about that in a clinic setting. And then what we were also discovering, as folks had alluded to yesterday, is that many patients are seeking aggressive, innovative treatments like clinical trials. They're on clinical trials that potentially are extending their life beyond the 6-month prognosis, and they're also seeking PAD as their backup plan. And so how to reconcile those two areas in terms of what those patients are pursuing. Our learnings have been to elicit all voices and listen. So it's kind of like doing a palliative care consult on our institution. And that some patients view this option as a backup plan, but not as the plan. And so particularly reconciling that with clinicians who view this as the last resort. And so how to engage in that dialogue. We already mentioned that, and that by codifying palliative care into our PAD process, we've become more recognized resources and support for clinicians and patients and families going through this. Thank you.